Hi, everyone. My name is Anne, and I am the host of Taking Questions on behalf of the After Party and on behalf of Womeness. And I am thrilled today to introduce you to Dr. Ekta Kapoor, who is an endocrinologist at the Mayo Clinic, as well as an expert in menopause, as well as women's sexual health. Thank you so much for joining me today, Dr. Kapoor.
It's my pleasure, Anne. Thank you so much for having me. It's nice to be here after almost 1 year, I guess it has been.
You were my first guest on Taking Questions over a year and a half ago. So thank you for joining us again. As you know, over 1 billion women are going to enter perimenopause by the year 2025. And yet there's so much we don't know about perimenopause. When I posted on our After Party community that I was talking to you, I got a tremendous amount of questions from our community. And so I'm hoping to get to them all today. But let's start with menopause. As we know, menopause is 12 months, a full year of not getting your period. You've gone 12 consecutive months without your period. What, however, is the definition of perimenopause?
Sure, no, that's a great question. And yes, I think we ought to start with the basics because like you're saying, it always amazes me and saddens me to see that when I'm giving talks about menopause and hormone therapy in the community and even to medical providers, how little people know about it. Yeah. So I, excuse me, definitely am with you on starting with the basics. So perimenopause, as the name suggests, peri meaning around. So it's that time period that is surrounding the final menstrual period. So it is the years leading up to the final menstrual period and 1 year after it. Now, the obvious question then, Anne, is that why should we make a big deal about perimenopause? It's menopause that we care about, right? The final menstrual period. We make a big deal about perimenopause for two reasons. Number one is the fact that this is the time when women are very likely to experience some very bothersome symptoms of menopause. So they come to us in our office at this time. It's not that they don't get symptoms till after the final period, and that's when we see them. We see them, many of them in perimenopause because they're oftentimes very symptomatic. The second thing is that, it's not just what you're seeing on the surface, meaning the symptoms of menopause. It is a lot of health risk changes are taking place at the same time. So they are gaining weight, their risk for cardiovascular disease is going up, their risk for diabetes is going up. So for the medical community, for the healthcare professionals, it is sort of a window of opportunity to sit down with these patients and intervene and alter their risk path going forward. So for these two reasons, perimenopause is very important. Now, clinically, how do we know whether a woman is in perimenopause? Symptoms, as I shared with you, which would be hot flashes, night sweats, and everything that we talked about in our previous interview here. But the thing that really defines perimenopause is change in the pattern of menstrual cycles. So it could be irregularity, it could be irregularity in heavy cycles, irregularity in light cycles. But if a woman is telling you that she's in her 40s or even late 30s for that matter, and her menstrual cycle pattern has changed and she's having some of these symptoms, then you know she's in perimenopause. The question that comes up a lot, and when seeing a patient like that, is, doc, how long do you think these symptoms are going to last for? How long will I be in perimenopause for? Mm-hmm. And that's really variable. I mean, it is up to 3 to 4 or 5 years maybe, but for some women, unfortunately, it can be longer. And there aren't good tools out there to predict how much longer we have remaining.
There are tools, or there are not tools?
There are not.
They're not tools. Mm-hmm. Yeah, that is unfortunate. And we know some of the symptoms, and there are so many symptoms. Mm-hmm. of perimenopause, like you said, the sleeplessness, the night sweats, the hot flashes, the vaginal dryness, the brain fog, mm-hmm. The loss of the sex drive. Mm-hmm. Some of the questions that we've gotten from our community surrounding perimenopause is one follower says that she's suffering from migraines mm-hmm. through perimenopause. And what are the best ways to manage the migraines? Are there any medications that are out there? Is it related to her cycle? Is it related to stress? What can she do?
That's a very good question, and it's a loaded one. And some of the points that your attendee is hitting are exactly right. The big player really in perimenopause itself are the hormonal changes. What do I mean by that? Let me walk you through the process of what we call premenstrual migraines, and right. So you might know of women who will tell you that they have migraines, or they may not even have migraines, but right before their cycle, in that 1 week that leads up to their menses, they can get very bad headaches. So two
Right.
scenarios: either they don't have headaches at all for the rest of the month, but they experience them in that 1 week window before their period, or they have headaches which are reasonably well managed, perhaps with medication, or not even well managed, but they clearly get worse in that window. So what we know is that in that week before the menses, estrogen levels drop. They are at their lowest right before the period. So it's that drop in estrogen that does not go well for some women, and it increases their sensitivity or lowers their threshold for experiencing these headaches, right? So what's happening in perimenopause is, and that your hormones are all over the map. So your estrogen, which is the main hormone that comes out of the ovaries, the lack of which causes many of these menopause symptoms and alters the health risk of a woman, that main hormone, estrogen, it's all over the map. You check it one day, it can be in the basement. The other next week, if you check it, it can be as high as 300, 400, perhaps even higher. So it fluctuates so much. So you can imagine that in the predisposed patient, if the hormones are going to be dancing around like that, that fall doesn't go very well. And because they are constantly changing, and not just in that week before the period, the frequency of headaches for a lot of patients can go up. So that's number one as to why it's happening. Then the question is, okay, how do we manage it? That's a very, very good question. It's a loaded question. So, if the woman is experiencing other symptoms of menopause or perimenopause at the same time, like hot flashes, night sweats, then hormone therapy may be a good option for a patient like that, because you're going to be managing those symptoms, keeping her hormones levels steady by giving her external hormones, and that'll probably help with migraines also. The one important thing to remember there is that if a woman has migraine with aura, then you don't want to be using oral estrogen, because it increases your chances of having a stroke, just the way migraine with aura also increases the chances of stroke. So you don't want to add to that. Now, what about a situation where you tell me that, the patient is not having any hot flashes or night sweats, and her only symptom of these hormone fluctuations are the worsening in the frequency of migraines? Then, one can have a conversation with the neurologist that should we just alter the headache medication somehow and manage it that way. But then even for isolated headaches, if the other medications are failing and she's really not able to control it with just pain meds, then using hormone therapy exclusively for this indication, as long as there is no reason why she couldn't use it, and there is a long list of those conditions which we have previously talked about, then hormone therapy is a reasonable idea. So I think this particular attendee who's asking this question, they just need to sit down with their provider and have this discussion, but they should know that there is a good reason why they are experiencing this worsening, and they can be helped. They don't have to sit in silence.
Right. And I think finding the right provider is the key. The next question that I had about migraines is one of our followers asked, what role alcohol plays, because she finds that with her migraines, and she gets them 4 or 7 days a week prior to her headache intensifies when she has alcohol. And when she went to her physician, the doctor just said, well, it's probably hormonal, and dismissed her. And her response was, that's a non-answer. That's not helping me. Just saying it's hormonal. How does that help?
No, that's disappointing. So, with migraines, a person who's had it for a long time knows that there are certain triggers. And those triggers, even though they belong in categories, they are not the same triggers for everybody. Not everything triggers migraine for people. And you may have heard friends mentioning things like that smells are a trigger for some patients. Smoking is a trigger for some patients. Alcohol is a trigger. So if this particular person has identified that alcohol is their trigger, then I think the obvious recommendation would be to cut back on alcohol use, because it is a known trigger. Is it a trigger for everybody? Should everybody be cutting back or giving up alcohol because they have migraines? No, but we all have to identify our own triggers and just deal with them and manage them. When it comes to management of migraine, and really the most important thing that we can do is identify triggers, lifestyle related or otherwise, and avoid them as best as possible.
There's so many symptoms to perimenopause, and women don't always know what those symptoms are. Of course, we know the obvious, the night sweats, the hot flashes. But what one was asking about anxiety. Is anxiety a sign of perimenopause? Because this particular woman was asking, I don't have stress in my life. My life is fine. And all of a sudden I seem to be having these anxiety attacks. And simultaneously, she has this weird itching that's happening. And she says, I'm not using a new deodorant. I don't have new, soap or detergent, but I'm getting this weird itching. Can those be signs of perimenopause?
No, very good question. Very good question. And I'll tell you why I think this is a very relevant point to discuss. Because to your point, if someone is having hot flashes and night sweats, that's something most women recognize as, due to menopause. And even if they're having it early on, like, a woman starts having them in her late 30s or early 40s, she's still very likely to think on the lines that this could be menopause related.
Mm-hmm.
But, it's these symptoms of mood problems and anxiety and sleeping difficulties that oftentimes do not get related to menopause, especially, if they're happening in the absence of hot flashes and night sweats. Right. So again, to your point, I have had women sitting in my office, women with medical backgrounds, women who are physicians, who are having bad mood symptoms, bad anxiety, and they're in the right age range, if you will, right? They're in the right age range. So they know menopause is coming, but they are unable to tie their symptoms to this big thing that they're almost expecting and anticipating. It's just sad.
Right.
So again, I think spreading the word about this, that it's not just about hot flashes and night sweats, even though they are really the most common symptoms, it is beyond that. And again, to the point of this question, this is a very relevant one. So yes, the thresholds for experiencing mood problems, the threshold for experiencing anxiety in the absence of any other changes are known to occur in this time that happens. Mm-hmm. Now, oftentimes, and such patients will give you a history of premenstrual worsening of their symptoms. Now, what do I mean by that? Just the way I was telling you about migraines, right? That the hormone changes, the fall in estrogen level can decrease your threshold for experiencing migraine. Similarly, women will give you a history that, I've had this for a long time. In that week before my periods, I would feel low, I would feel anxious, I would feel edgy. And then after I had my baby, so the postpartum phase, that's also a time when your estrogen levels are low. I mean, you get used to having so much estrogen flowing through your veins when you're pregnant, and then it just plummets after the baby's born, right? So that's another vulnerable period, if you will. And a lot of women will experience symptoms of a lack of estrogen at that time. So you will, if you dig deep enough, oftentimes get that history, a patient telling you that, I have been prone to this, but it's not always the case. So again, a woman in the right age range experiencing new onset anxiety or depression, or someone who's had these conditions chronically for a long time, but is clearly experiencing worsening, could very well be due to hormonal changes of menopause.
And the same for, I had some questions about acid reflux.
And answering the second part about the itchy skin. So, even though one cannot directly ascribe the symptom of itching per se, but menopause for sure, the hormone changes cause a dryness everywhere. So if dry skin is leading to itching, which it very well can, that's the association I can think of. But the skin in general does not stay as healthy, with lack of estrogen. But then again, we don't endorse using estrogen for making skin healthier, but changes of aging and dry skin do surface due to lack of estrogen.
So, and those symptoms like the itching and then this one, acid reflux, which is also something unusual that this particular woman is experiencing. These are changes and things that can be tied to perimenopause, even something like acid reflux.
Acid reflux, not necessarily, because I can't imagine of a mechanism that would cause acid reflux, but then again, there could be related things like, for example, midlife women tend to gain weight, right? So, and obesity, weight gain is known to be a risk factor for acid reflux. So it may be indirectly related. And then, stress-induced lifestyle choices. Somebody starts eating differently because of the stress induced by their symptoms or otherwise, and that's causing them to have acid reflux. But there wouldn't be a direct association between lack of estrogen and acid reflux per se.
Okay. I had another question. This woman was taking estradiol and progesterone, and one night she forgot to take it. So then she later started her period, and a week later she's still spotting. So if you're on medication and you miss your medication, what is the protocol?
Yeah, very good question again. So let's just go back to the basics again here and understand what are the two components of hormone therapy. So for in a woman who has an intact uterus, which this patient obviously has because she's experiencing the bleeding, we have to give another hormone along with estrogen, which is progesterone. So, estrogen, like I've said a few times, is the main hormone, the lack of which causes symptoms, the lack of which increases the health risks. So even though it would make sense to just supplement a woman with estrogen to take care of all of this, we cannot give it by itself because unopposed estrogen on the uterus can cause increase in the size of the lining and even predispose women to cancer of the endometrium, cancer of the uterus. So for that protection purposes, women have to receive some form of a progestogen. And that's usually like an oral progesterone or even a IUD like a Mirena IUD, which releases a progestogen. So let's say you miss one night's dose of your progestogen. Because the purpose of that is protection of the endometrium, you are likely to experience bleeding, but a single dose shouldn't do it. So if you miss the nightly dose, it's okay to take it the next morning. It's even okay to take double the dose the next morning. The protocol is going to be different depending upon what specific hormone therapy regimen you're on, but contact your provider, if you are missing the dose. But again, missing a single dose should not cause trouble. It is when you miss several doses that problem happens. But like I said, if you are on progesterone tablets and you miss your nightly dose, it's okay to take it the following morning or take double the dose the next day. It's just fine.
You've talked about hormone replacement therapy. Can you describe how HRT works?
Okay. So, and the first thing I'm going to say is that, in this context, after natural menopause, we don't call it it's semantics, but I just want to call it out. We don't call it hormone replacement therapy because if you think about it, and it's really not replacement in a sense, right? That's why the North American Menopause Society now makes it a point to call it just hormone therapy or menopausal hormone therapy. The one exception, Anne, would be, these young women who go through menopause at an early age for whatever reason, either spontaneously or because their ovaries have been taken out, or they've had chemotherapy that's knocked out their ovaries, or they've had radiation and that's knocked out their ovaries. So that's premature menopause before the age of 40. So these women are given estrogen therapy not just to manage their symptoms, Anne, but they are given estrogen therapy to prevent the long-term bad stuff that happens when a woman doesn't have estrogen flowing through her veins. So in that context, we call it hormone replacement therapy because it's clearly a lack of estrogen that we are replacing. But for the average woman after natural menopause, we like to make that distinction and call it just hormone therapy and not hormone replacement therapy. So that was that. So what was your question about hormone therapy?
Well, so if you could, when would you start to take it? Is perimenopause too early, or how long into postmenopause would you be using it? One woman had asked, how long should you stay on it? She's 56 years old and she had been on it since she was 45. So it seems like there's a lot of questions on exactly what it is, when you would go on it, and for how long should you be on it?
These are all very good questions. And there's, again, a lot to say here. So I think I'll take a few minutes to go through each aspect of these questions. These are all talks in and of themselves, and there is so much to say there, but very, very relevant and excellent questions. I'm glad they've come up. So to answer your question as to when do we start it, again, it depends who is the patient in front of us. So if like I was telling you a few minutes ago, that if you are dealing with a woman who has had premature menopause, meaning she's become menopausal for whatever reason, prior to the age of 40, or she has early menopause, meaning she's become menopausal between the age of 40 to 45. And the important message that I've tried to say loud and clear on my talks and when I'm talking to patients is that the purpose of estrogen therapy there is not just management of symptoms. It is to prevent the long-term bad things that happen when a woman's estrogen is taken away from her. And as an example, those things are heart disease, dementia, diabetes, osteoporosis, early mortality, and a host of other problems. So it is increasing recognition that, the thought used to be a few years ago that when a woman who's done with childbearing, her ovaries really have no function and they can come out to reduce her risk of ovary cancer. So like if you are in the pelvis for any reason, taking her uterus out because she's having heavy bleeding, it's okay to take the ovaries out. We have completely moved away from that line of thinking because it's completely wrong. Actually, I would go to the extent of saying that childbearing is not even the most important, or supporting childbirth, not even the most important function of estrogen for a woman's own health. It is so many other things that the estrogen hormone supports, and there's increasing recognition for that. And we know that unless there is something like breast cancer, for which reason we want a woman not to be exposed to estrogen, there is no reason why a woman should be stripped of her estrogen prematurely. So in these young patients, to answer your question about when do we start it, if I have a 35-year-old in my office who's had both her ovaries taken out, even if hypothetically she tells me that she has zero symptoms of menopause, what do you think I'd be doing in terms of hormone therapy for that patient? I'd absolutely be putting her on estrogen for improving her long-term health. So there, my goal is not managing symptoms. Okay. So I think we think of this thing very differently if we are talking early and premature menopause. But then the garden variety natural menopause. So if I have a woman in her late 40s, early 50s sitting in my office because she's symptomatic, so then we start when her symptoms are impacting her quality of life, because the goal there is different, and the goal there is treatment of symptoms. See the difference? So after menopause, natural menopause, the goal is treatment of symptoms. Mostly. In some cases, though, it is improvement in bone health also, although we have other medications that can be used for that purpose. But sometimes we can use hormone therapy for that indication also. It's a minor indication. So in contrast to younger women, where the goal is just hormone replacement. That's why we make that distinction. So that's question number one answered there, that when do we start it? How do we start it? So, like I've said before, the main hormone that really needs to be given is estrogen, right? And that estrogen can be given as a pill, or it can be given through the skin as a patch, as a gel or a cream. And in women who have an intact uterus, then they need to have some form of progestogen. It can be oral, it can be the Mirena IUD. And in terms of what specific regimens and what specific doses we use, and that might be too much detail to go into here, but suffice it to say that if I have a younger patient in front of me, I will be going with full-blown replacement doses, high doses, because the goal there is, Anne, to make her estrogen level comparable to what a woman would have if she had her ovaries intact, right? So there, because the goal is replacement, I go with high replacement doses, versus a woman after natural menopause. If I'm just trying to manage her symptoms, you can start low and gradually build up to a dose that manages her symptoms. That also brings us to an important point, that do we target a specific level of estrogen when we are treating women after natural menopause? And the answer is no, because there's a big industry out there. I get these questions all the time about checking and monitoring hormone levels, right? People are very eager. These labs that want to make some money out of this, they want to be checking hormone levels on patients. They want to draw their blood to check these hormones. They want to check their hormone levels in saliva and all sorts of body fluids, but there is no science to support that. So we're not targeting any specific hormone levels in women after natural menopause. What we're really after is treatment of symptoms.
Right. So I've had some women ask, because they've had a hysterectomy, they're not having menopausal symptoms. How do they know they're in menopause?
Yeah. And I'll get to that here in just 1 second. Let me finish answering the previous question in terms of duration, and then I will come to that. So in terms of duration of treatment, I keep a couple of things in my head. So even though there are no strict guidelines out there as to how long you treat someone for, remember a few things that, like everything else in life, when you're starting somebody on hormone therapy, you're looking at the risk-benefit balance, right? So when you have a young patient in front of you, who's 51, 52, the benefits are treatment of her symptoms. But at the same time, hormone therapy in a young patient like that is reducing her risk of osteoporosis, reducing her risk of heart disease and diabetes. So it's giving some additional benefits, even though the goal of treatment is not that, but that's like a side benefit that you get. The risk for a young patient is minimal. The only real risk is a minor risk of clotting, which is mainly the case with oral estrogens and some form of progestogen. So, and the risk-benefit balance is clearly in the favor of benefit for a young patient. So let's walk through what happens 5, 6, 7 years down the line. How does that risk-benefit balance shift? It does shift a little. Number one, the main reason why you started the patient on hormone therapy to begin with was symptoms, right? Those, for the most part, for most patients, tend to get better with passing time. Okay, so the main reason why you started hormones is getting better. The preventive benefits, like reducing the risk of diabetes and heart disease, etc., are not as strong in women who are beyond the age of 60. And the risk, breast cancer risk, potentially, it's a small risk with hormone therapy, nothing to be afraid of in an average risk patient, but it does go up with dose. So high doses used for long periods of time probably do increase your risk somewhat. So can you see how the risk benefit balance changes a little? That's why in my practice, after 5 to 6 years of use, for all these reasons, I make an attempt to get my patient off of hormone therapy. 90%, 80 to 90% of the times I'm successful because their symptoms have gotten better with passing time. But 10 to 20% of patients have rebound symptoms when their hormone therapy is stopped. And then the question in front of us is that, do we go back to hormone therapy or do we try something non-hormonal at that point? And that's between the patient and the doctor. Mostly patient's decision. But what I do at my end is just inform them of all potential risks, all potential benefits. And the main thing that I fear at that point really is the breast cancer risk with extended use, which isn't the case when I'm first starting it. So it does change with passing time. That's the thing to keep in mind. And you know, I've had patients tell me this, Anne, and I get it. They will be like, okay, you're telling me that there is maybe an increased risk of breast cancer. It's not a definite small risk. I may never get breast cancer, but the way my symptoms are right now, I cannot keep living like this, and quality of life stumps everything. And there's no arguing with that, right? So I relate to it, I understand it. And then after discussing pros and cons, I let patients continue hormone therapy for longer periods of time if they want to. But as their provider, I inform them of every possibility that exists out there, the pros and the cons. And if after hearing that my patient wants to continue hormone therapy for an extended period, I let them. I have 70 and 80-year-olds on hormone therapy, but it's an informed decision on their part. So that's about the duration. So it's a loaded question, not a straightforward one, but these are the discussion points, you know, that I have with patients. Now, coming back to your next question. So if she's had her uterus taken out, then she really cannot rely on the lack of menses. Then how does she know? So in such patients, usually, and if she's in the right age range and she's having the characteristic symptoms, then we know that she's going through menopause. Sometimes what happens though, and this is a reasonably common clinical scenario, let's say a woman has her uterus taken out in her 30s for whatever reason, right? She's having heavy periods, which is the most common reason to do it. These women sometimes can lose their ovarian function earlier than the natural age of menopause. And one of the theories for that is that the blood supply to the ovaries gets compromised during the surgery on the uterus. So, you know, she had her uterus taken out at 35 and you're seeing her at 38 and she's saying, I'm having hot flashes. And you're going, 38 is not the age to have hot flashes. I would expect menopause in the age range of 46 to 55. In a patient like that, I would probably check hormone levels to be sure that this is what is happening. And why we need to know definitively at that point is because at 38, if she's indeed in menopause, it's premature menopause. And then from what I've told you before, in this patient, even if she didn't have symptoms, we need to have her on estrogen. So there, I think the diagnosis will become critical. But let's say a patient who's had a uterus taken out and is experiencing hot flashes at 47, then do I need to do hormones? Probably not, because, you know, that's the natural age of menopause. She's having symptoms. I just go ahead and treat the symptoms unless the patient tells me, no, I think I'd like to know where am I? So if patient demands it, I check it, but there is no reason to check it. Does that make sense?
Absolutely. And thank you for answering that, because that question did come up a few times, as well as women who are stroke survivors. So what is the relationship between this, the hormonal therapy, and women who have had strokes? Are they eligible for it? What advice can you give them? What do you think?
Very, very good question. And again, a loaded one. So
Yeah.
if you read textbooks and about menopause and hormone therapy, stroke is listed as a reason to not give hormone therapy. So it's what we call a contraindication. So, if this person is being seen in the community, their provider will probably tell them that they couldn't be. But, being that we practice in a tertiary care medical center, and I tend to see some zebras, so I do tend to stick my neck out every now and then. I can give you a few examples from my own practice, how I've dealt with stroke survivors. So I have a young lady in my practice. When I first started seeing her, she was in her 30s, so professional, high achieving professional, ovaries taken out. And she was told because of the history of stroke, she couldn't be on estrogen. Completely miserable, not performing at work, just the whole 9 yards.
Right.
So she had been told repeatedly she couldn't be on estrogen, but I stuck my neck out and put this patient on estrogen because, again, this discussion of that, okay, your risk of stroke is probably higher on estrogen. But the thing to remember there is that it's mostly with oral estrogen, not so much with estrogen given through your skin. But there are people who might be nervous even using that in stroke survivors. So I started her on a low dose given through the skin, built it up gradually. And yes, I'm not giving her the full-blown, the so-called replacement doses, but I have her in a middle of the range estrogen given through the skin, and that's changed her life. So even though we don't have any evidence, like, no randomized controlled trial showing us that transdermal estrogen does not increase your risk of stroke, but there is good enough observational evidence. And what do we mean by that? That we've seen patients on transdermal given through the skin estrogen and their stroke risk does not go up. So on the basis of that, just using common sense and looking at the patient in front of you, how her life had just fallen apart, I have given it to her. But then again, this was a young patient with complete lack of estrogen. What if I am seeing a patient who, after natural menopause in her late 40s, early 50s, and she's a stroke survivor? What would be my approach to a patient like that? In that patient, I would first try to do something non-hormonal. So I wouldn't even take the risk of putting her on estrogen through the skin as my first step. So I would try a non-hormonal strategy for this patient. And if it works, which it does for many patients, well and good. Because again, and I cannot emphasize this enough, because the goal in this patient who's in her 50s is symptom management. It's not estrogen replacement. But my high achieving professional in her 30s, the goal there was estrogen replacement, right? So that's why it was almost like depriving her of this very essential hormone at her young age. So in my 51-year-old, I would try something non-hormonal, give it a few weeks, see how she does. If that doesn't work, I try another non-hormonal. There are 2-3 that work very well. But if I see that none of them is working, then I think it again becomes a matter of quality of life issues, sitting down with the patient, discussing pros and cons, and letting the patient make the decision, an informed decision. And I would not take it completely off the table. I never do. I mean, there is more and more acceptance for even using estrogen low doses in breast cancer survivors and patients who have tremendous quality of life issues. So that's the point we have come to now, because at the end of the day, the patient sitting in front of you is the most important source of information that you have to keep in mind when you're making the decision. So again, stated in summary, for a stroke survivor, a young patient, they probably will still be a candidate for estrogen therapy, but given in low doses through the skin. In the older patient, and older also relatively speaking, a 50-year-old is not old by any means, but she's still a young postmenopausal patient, but a patient after natural menopause, because my goal is not hormone replacement, my goal is treatment of symptoms. I try something non-hormonal first, but would not take hormone therapy completely off the table for a patient like that.
So when we're talking about education in general about perimenopause and menopause, when should you start talking to your doctor about symptoms? And what should you know before going into see your doctor? And what should you expect in the appointment?
Have you been reading my mind of late? I just have to smile really that you're asking me this question. And I haven't seen all of these questions ahead of time. So it's really just making me smile because that is sort of our latest mantra now, that we do not wait to get into our 40s or even our 30s to receive this menopause education. I had a high school student who did a women's health project with me 2 years ago. And what she did was that she asked this question in the community in which we live. She asked women how much they knew about menopause and how much they knew about hormone therapy. And the results were just mind-boggling and disappointing because even the very well-educated people in our community, and they were responding in not an anonymous way. So I knew who all were giving out these responses. It was just heartbreaking that, those were the kind of results we were getting. So this high school student, in fact, made a comment to me that I think we need to start educating very early on. And some of my colleagues at Mayo Clinic, we talk about this, that just the way we give the puberty talk to middle schoolers, elementary school kids, right? We have to give the menopause talk early on. And why not? Because our thinking is that if starting of the reproductive phase of life is considered so important that we spend so much time counseling our little children about it, right? This is important phase when this reproductive stage ends, and a woman based on the current lifespan is likely to spend one third or more of her life in that phase. Why could we not spend the time and resources to educate women about this so important change? And if you think about this for a minute, you pause and think, it'll give you goosebumps and you will go, really? Have we been failing so miserably? And we have been, actually. Can you imagine? It's such an important change. Majority of the women are going through this change, knowing nothing about it.
Right.
So in this survey that I was talking to you about, this high school survey, one of the persons put in a comment that it is the most odd thing. No one talks about it.
Right.
No one talks about it. And should it be a taboo subject? Is it something to be ashamed of? It's a natural change, right? So I think, again, to your point and to your question, our latest force really is that we want to start early. We want to catch women early. One of the recent studies showed that amongst the developed nations, the mortality rate, so the death rate, in women in the reproductive age group is one of the highest in this country.
That's amazing. That is so unfortunate.
It is just so sad. Are we the most developed nation in this world? And this is the state of affairs.
That's unbelievable.
Yeah, it is just so sad. So I think our biggest force at the Center for Women's Health at Mayo Clinic now is education. And education, not just of the providers, education of our patients, of our community. And, I've said this before in one of the women's forums that I am a firm believer that I think we will get the greater bang for our buck if we educate our patients. And the reason why I say that is that as women, we are go-getters. We are motivated people. We make change happen. We take care of the health of our family. We run our families. So if we are educated and we are given those tools, what I foresee happening is that women will be going to their providers with that information, with those tools, with those resources, that armamentarium, and then discuss the plan that they want implemented with their provider, rather than sitting there with a sense of helplessness and ambivalence. That's the worst. They sit in the offices of doctors wondering, should I even bring this up? Is there even something that they can do about it? Will he just distract me and divert my attention and tell me to talk about something else? So we approach with ambivalence. So the provider sitting in front of us senses that also, and it's not considered as an important issue. Versus if I go in with that sense of confidence that there is no ambivalence about this, these are symptoms, this is health risk, and I want this managed, and this is how I want it managed. Don't you think the provider's approach would be very different? So that's why I feel like the education really has to be of the patients, the community. And that's where we are diverting a lot of our resources now, because I think we will get most bang for our buck. And I'm a firm believer that we have to start early.
Right. And that's what we're trying to do at Women S, and certainly with the after party, is number one, break that taboo. And number two, give women the confidence to go and talk about this, and not just with their doctors, but with their girlfriends, with their mothers, with their daughters. It's such an important subject. And I always say, we're all in it together. So we're trying to lift each other up and get answers and feel confident about asking the questions. One of the topics that come up often on the after party, and I'm sure you hear it a lot, is that weight gain that you get when you're heading into menopause in that midsection and dealing with the bloating. Is there anything that you can recommend that women can do to help with that, to help reduce the bloating, anything to manage the weight gain?
Yeah, you're exactly right. That's a question I get a lot because it's such a common issue and it is a very devastating issue, right? So, again, we did a little survey in our clinic and what we found and was that even though hot flashes and night sweats are the commonest symptom of menopause, the things that bothered patients the most in terms of, going through midlife, the two things that came up were weight gain and sexual dysfunction. So again, it's a matter of what causes greater bother. So women are somehow able to put up with the most common thing that menopause brings, but weight gain can be hard. And again, to your point about the change in the midsection, a lot of times what happens is and that they may not even gain weight. Really, the scale may show the same reading, but their body feels different. And what really is happening, they're losing muscle mass and they're accumulating more of that fat in that midsection. So things are getting redistributed. So the overall weight doesn't change, but they look and feel very different. So the hard part though is what do you do about it? And let me just speak a little bit to what is the cause for it. Weight gain itself is more a result of the changes that aging brings in. So even men are not immune to it. It's the way our metabolism is changing. It's the way how we are moving around. So, as an example, you ask a 20-year-old to get up from their chair and go up the stairs and get something. And you ask a 50-year-old, one may think that they should be spending the same amount of energy in doing this exact same activity, right? They don't. It's different. We burn fewer calories as we get older because our muscle mass is going down. So we're recruiting fewer muscles to do those same things. As I'm sitting here and talking to you, I'm just burning a very basal amount of calories, right? Whatever, I'm doing the essential stuff in my bodies, I'm just burning those calories and my muscles, just some baseline energy is being burned. But because my muscle level, the number of muscles or the muscle mass that I have is lower than what I had when I was 20, I'm burning fewer calories. So a lot of it is beyond our control. So, the one comment I get a lot from my patients, Anne, is that, doctor, I haven't changed a thing. I'm eating the same way. I'm exercising the same way. And I'm still gaining weight. So unfortunately, the response to that is, that's partly why, because things do need to change because there are changes happening inside us that we need to counteract. So that is mainly age-related changes. But, with respect to the body fat distribution changes and loss of muscle mass to some extent, that's menopause mediated. Lack of estrogen is directly responsible for those body composition changes. What to do about it? Even though, intuition may make us think otherwise, that, okay, as we get older, it's okay if we can slack a little bit in physical activity. The truth is just the opposite. It takes more work. I have to work harder to maintain weight and even harder to lose weight as we get older. So our eating habits have to be very different. Caloric intake has to go down. And activity level, even if you were to keep it the same, not intensify it, because it would be hard to expect as we're getting older to keep intensifying our physical activity. But at the end of the day, the caloric consumption has to keep going down. So substituting those high calorie things with more fibrous things, which fill up your stomach, but do not add to the caloric burden, is that way to approach it. Eating healthier.
The last question I have is that we've heard that menopause can be a different experience for women of color. Is there anything additional that you'd want the persons of color in our community to know or be especially aware of when they speak to their doctor?
Very, very relevant question. And I really have to compliment on you on the quality of questions that you have received here. I think these are very insightful and initiated women who are asking these excellent questions because, again, I think this is one of the areas of active research and active work now. It really is. And I'll tell you why. So there is good research to show that the experience of menopause is dependent on race and ethnicity. It varies based on that. So African American women, for example, tend to have worse menopause-related symptoms, worse hot flashes and night sweats compared to Caucasian women. Asian women tend to have them milder than the Caucasian women. So there are race-mediated differences in just how the experience of menopause is. What, however, is worse, and I say that it's worse because, race or ethnicity mediating menopause symptoms is something we can control. But the second component that race and ethnicity brings is something we absolutely can control, and we're actually guilty of it. The quality of care received by some of the minorities is worse than what the other patients receive. So that's something that can be fixed, and that's why it's an area of active discussion and active research. I mean, there are anecdotal reports, there is research to suggest. We recently did a symposium on this very same topic where, issues like these came up, that African-American women tend to feel dismissed more by their doctors when they are talking about menopause symptoms. The resources and the recommendations that are offered to them are inferior to what would be offered to a Caucasian patient. These are real issues in the society, and sad, very sad. And especially in the current climate, the other issues that we're dealing with, the racial discrimination. So menopause is not immune to that. Menopause and its treatment. So that's something we can do a better job of. Again, having the awareness that if you are dealing with a minority, her menopause experience is likely going to be different. So almost preparing for it, anticipating it, and preparing your patient for it, right? So that having some sort of brochures or education materials. So again, as we were talking earlier, that when do we start? We start early, and we tell these patients when they are in their 20s and 30s that, down the line, this will be the experience. This is what the landscape will be. And your experience is likely to be different from your white friends, for example. And then preparing for it, anticipating it, and offering them equitable resources rather than having a discrimination on the basis, which unfortunately, like I said, does exist.
Well, Dr. Kapoor, I cannot thank you enough on behalf of everyone at the after party, on behalf of Womeness. I thank you very, very much for your time and your thoughtful insights into this journey.
No, it's always a pleasure to be here. And you know this, you've known me long enough that this is something I'm so passionate about. So if I get these opportunities to educate people, to talk to them, I really enjoy it. And, that's why I appreciate the work. And you alluded to it, that you are doing at Womaness, because my main goal really is to educate our people. And I think you're doing a fantastic job. It's going to be a long road ahead, no denying, one step at a time, but we've got to start somewhere. And I'm very glad that people like you have taken that initiative and are making this a beautiful and easier journey for people like us, because we can reach more people through you. And I'm glad for that opportunity.
Well, thank you.